Hi, and welcome to the Immunisation Update, including new schedule and changes. My name is Brooke J, and I'm the Clinical Engagement Manager at Sydney North Health Network. So I'd just like to acknowledge Australia's Aboriginal people as the custodians of the land. We pay our respects and recognise their unique cultures and customs and honour their elders past, present and future. A little bit of housekeeping for this evening. If you do have any questions for the speaker, you can use the Q&A feature found at the bottom of the screen. To interact with each other, you can submit questions via the chat box to each other or to all panelists. And we will endeavour to get to most questions. We would ask that you do ask questions that are relevant to the topic being asked at the time of the presentation. And if it's a more general question around immunisation, there will be some time at the Q&A session at the end of this evening. We would ask that at like a face-to-face event, you are respectful to one another and you would behave as you would at a face-to-face meeting. If you do have problems with your screen freezing, you may want to try to move closer to your Wi-Fi connection. There will be an evaluation at the end, at the completion of this webinar. If you could click on the link to the evaluation, that will ensure that we are meeting our RACGP requirements and also to ensure quality assurance of our webinars. So I'm going to pass over to Dr. Justine Morris, who is a GP and a clinical editor of our Health Pathways team. Justine is going to give a brief presentation and demonstration of the Immunisation Update, the Immunisation Health Pathway, including some recent updates. So Justine, we'll go over to you, but before we do that, I will also now introduce Sally Edwards, who is our keynote trainer for this evening. Welcome to Sally. She is the CNC Immunisation Coordinator at the Public Health Unit. I'm sure many of you know Sally. She's worked as the Immunisation Clinical Nurse Consultant at Northern Sydney Public Health Unit for the past 6 years, and in this role has provided immunisation education for clinicians and the general public in the high school vaccine program for Northern Sydney Local Health District. And she also manages a team of nurses and support personnel. So we're very lucky to have Sally tonight to give this training. So Justine, we might hand on over to you now to do the Health Pathways demonstration and then we'll get started.
Great, thank you so much, Brooke. So as Brooke mentioned, I'm one of the clinical editors for Health Pathways. I won't keep you long. I'll just quickly introduce Health Pathways and do a demonstration on the live site to show you an example of one of the immunisation pathways relevant to this evening's webinar. So I'm hoping that by now most of you have heard about Health Pathways, but just to recap, it's a website full of really useful health information targeting GPs and other health care professionals, with lots of information about a multitude of different conditions, as well as, probably most helpfully, information about services very specific to our region, so within the Northern Sydney HD, and including all those telephone numbers, information, referral criteria, forms, etc. can be hard to find, so they're all in one place. As well as access to reference materials and resources for both and clinicians. I mean, so really for me, what makes Health Pathways differ and stand out to all the other guidelines out there is that it's very specific and tailored for our region. So, you know, when you're practicing in this region, and the way they're developed is in collaboration with secondary care colleagues, with whom we work together to develop a streamlined pathway for management and referral of various conditions. So it really is a useful resource. So as you can imagine, there's plenty of benefits both for patients, clinicians, as well as the wider LHD, mainly in terms of better coordination and communication between primary and secondary care and more effective use of resources. So a snapshot about Health Pathways so far. So we've been live now for just over 3 years, with nearly 400 pathways live and an average of 4,000 views per month. And those numbers are increasing as the word is getting out there, which is great. And here's just a summary of the immunisation pathways that we have on our site so far. So as you can see, covering a range of different topics, and probably the first two are the most relevant to this evening's webinar. You can see that if you hover over these links, and this presentation will be sent out to you afterwards, you can just click straight to it and it will take you to the health pie. And you can log on some regular details. Again, you will get sent the login information in the post webinar communication, so with all the username and password. So I'll just flip to the live site now. So when you go onto the live site, this will be the home page that you see, and you can see there's lots of useful links to various things on the side, and if you go down, there's lots of news items, including top of the news, the immunisation programme changes, with links to the relevant pathways which have all been updated very recently to reflect those changes. So to access those pages, obviously you can click straight from here, or the more usual route is through the contents bar on the side. You'll find the immunisation pages under public health. If you just expand those menus, you can see the ones in heavy dark font are the ones that have been localised for our region. Alternatively, you can just use the search function by typing in a keyword, just make sure the spelling is correct. So for example, if you pop immunisation in, you'll get again the ones relevant to that. So as an example, I'll open up the childhood immunisation page so you can see what it looks like. A lot of pages at the moment have a COVID-19 note at the top where things have had to change due to the current situation, as well as useful links to the relevant guidelines. Some pathways have a clinical editor's note at the top if there have been some major changes. So, for example, the National Immunisation Programme changes. There's a note about that and at the top of this pathway with relevant links to all the useful resources. And then the rest of the pathway really is quite self-explanatory, with red flags, assessment, management, requests, which is just another name for the referral information. And as I said earlier, that's really what's got all the useful information about relevant to our region. So for example, Northern Sydney Public Health Unit information, as well as any clinics or immunisation helplines you might need to call for help with patients. As you can see, there's lots of drop-down boxes that are closed. If you want to go through the pathway in detail, I suggest you just expand all at the bottom and go right up to the top, and then you can scroll through going through everything in detail. There's also a send feedback button at the top right hand of the page, so if you want to send back feedback, we're always happy to receive it. So I'll just end shortly, just to summarize really by saying that you know, we'd love you to use the resource. Clearly I'm biased, but we think it's a really useful resource. You know, I use it in clinic with my patients, and it's really great if you know, need a reminder about you know, the best management pathway for something, or want to know what the referral criteria is to get a patient into a clinic at one of the public hospitals, or even also there's private referral information as well. That's also there. So probably the easiest way to use it easily is to have a shortcut on your browser or on your desktop. And just to mention, we now have a GP liaison, Dr. Helen Wainwright, whose contact details are there, who is very happy to come to the practice and help you set it up and show you how to use it, or to do things remotely, whatever you prefer. So that's really it. That's just some more contact information in case you want to get in touch. So thank you for listening, and I'll hand over now to Sally.
So today we're going to cover briefly the minimum core requirements for authorised nurse immunisers, and having a look at the national and New South Wales schedules and changes, a review of the current vaccine preventable disease activities, some catch-up immunisation, adolescent and adult vaccination, and any other changes that have been happening for 2020. Just to recap the core requirements, there are 5 of them. The first 3, the New South Wales Immunisation Authority, for registered nurses and midwives, vaccine storage and management, and vaccine administration. They're included in your readings, which I sent out to you. So hopefully you've done those or started on those, and they can be done in your own time, and then you're keeping a log of the time spent doing that education, that self-directed education. Today, we're going to cover the other two components, and that is the New South Wales immunisation schedule and current situations, issues and update. And that's also the national immunisation schedule as well. That'll be covered today. So those two core requirements revolve around the current immunisation schedules, the differences between the NIP and the New South Wales schedules, catch-up vaccination, the school vaccination schedules, maternal influenza and pertussis, neonatal Hep B, healthcare worker vaccination, and also current issues and updates, which is the vaccine preventable diseases, what's going on with those, and any other topical issues as well. So starting with the National Immunisation Program, you'd all be aware that that has changed as of the 1st of July this year. And this is the new schedule as we know it now currently, and it's now been divided into two schedules. This is available on that web link, and it is the overarching schedule for the entire country. So it is published by the Commonwealth, and then each of the states do their thing with it. So with this latest iteration, there is a schedule for non-Indigenous people, and then they have now included a schedule for all Indigenous people, and you can find them via those links. And this is the New South Wales immunisation schedule, which has been updated from the 1st of July. So you can see it's looking at quite a bit different, not only different in the additional vaccines that have been included on this schedule, but they've also included a lot more information for each of those age groups to help you determine what needs to be given at that particular time and age. So you can find that at that web link below, but you've probably all been sent the schedule out and have already got that up on your walls. There's also additional to the schedules, both Commonwealth and states have additional vaccines that you won't find on the schedules. So for Commonwealth, you'd all be familiar with the ongoing catch-up for 10 to 19-year-olds that have been going for a couple of years now. That's for DTPA, polio, measles, mumps, rubella, varicella, hepatitis B, human papillomavirus and meningococcal programs. And that's an ongoing program funded by the Commonwealth. They also do an ongoing catch-up for refugees and humanitarian entrants aged 20 years and over. So they do DTPA, polio, MMR, hepatitis B and varicella for 20 years and over for refugees and humanitarian entrants. In New South Wales, we supplement that as well with some additional things. So we do hepatitis B vaccination for risk groups, so Aboriginal people, household contacts with people with hepatitis B, immunocompromised people, men who have sex with men, injecting drug users, sex workers, and clients of sexual health, sex workers. We also offer HPV for refugees and humanitarian entrants from 20 to 26 years of age. So that extends on the Commonwealth program. MMR, measles, mumps, rubella, that is offered to unvaccinated people born during or after 1966, and rubella seronegative postnatal women. And we do rabies post-exposure prophylaxis as well. So that's for anyone exposed to a bat in anywhere in the world, but in Australia, the only animals that carry lyssavirus, the rabies type virus, are bats. Outside of Australia, we provide that post-exposure prophylaxis for any animal bites, scratches, well, for any animal, terrestrial animal, or bats, and any land and terrestrial animal. You just need to contact us and we will do a risk assessment. But that post-exposure prophylaxis, the immunoglobulin and vaccines are all provided free by New South Wales Health. Okay, so throughout the presentation, we're going to be doing some polls. So I'll ask you a question and I'll give you a few seconds to answer them. So this first poll, put my glasses on because I'm getting old. And I'll just give you 30 seconds or so if you can just nominate your answer to that to let us know who you think are entitled to the free catch-up vaccines. Okay, that's great. Lots of people answering, and the majority are going for the third response. I might close the polling now. Thank you everyone who participated. I also point out these are anonymous, so I've got no idea who answered what, so feel free to chime in whenever you like. So yeah, the majority have got that one right, which is good to know, and that is eligibility for the free vaccines are linked to your Medicare benefits. So essentially you need to be an Australian citizen, a New Zealand citizen, an Australian permanent resident, applying for permanent residency, or it's covered by a ministerial order. So that would cover refugees and humanitarian entrants as well. So essentially anyone that falls under those categories are entitled to free vaccines under the National Immunisation Program. Okay, so what's new? What's new in 2020? There's a lot new in 2020, and you might have been aware of the changes to the schedules. So I'm going to go through those to start with. What diseases were affected by the changes? Pneumococcal, meningococcal B, meningococcal ACWY, and the Haemophilus influenza type B, and hepatitis A, but only applies to Aboriginal children and not in New South Wales, so I won't be covering that. So the pneumococcal vaccination, which is a Prevnar 13 and Pneumovax 23, those changes apply to at-risk groups of all ages, Aboriginal people over 50 years of age without medical conditions, non-Aboriginal people over 70 years of age without medical conditions, and Aboriginal children, but not in New South Wales, so we won't be touching on those. So the changes apply to, if you for at-risk groups, you may recall if you've had a patient who falls into an at-risk category, so they're at an increased risk of invasive pneumococcal disease. Used to be separated into two categories, and depending on their risk condition, they either fell into category A or category B, and they had two different schedules. So to reduce complication, we've got rid of the category A and Bs, and it is now just a list of single list of risk medical conditions. And that's the list to the right there. You can find this resource on the link below, which is a very important resource because those are a lot of risk medical conditions. All of them are recommended to receive pneumococcal vaccination, but only a handful of them are funded. So it actually tells you what the recommendations are and which medical conditions receive a funded vaccine. So it's a lot more streamlined and a lot easier to follow than it used to be. Pneumovax 23 has now been limited to 2 lifetime doses. So it used to be a 3 lifetime dose, and that's now been reduced to 2 lifetime doses. So regardless of the age they were received, they're a lifetime of 2. For children under 12 months of age with a risk medical condition, the changes do not affect anyone, the normal childhood schedule. So you recall last year when the National Immunisation Program was updated, there were changes to the pneumococcal schedule around the ages that we gave it. This time the usual childhood immunisation program hasn't changed and aren't affected. It's to do with the risk medical conditions. So essentially, children with the risk medical condition receive an additional dose, which they have always done, at 6 months, or at diagnosis if they were diagnosed at 6 to 11 months of age. They then receive Pneumovax 23 at 4 years of age, and an additional dose of Pneumovax 23 at least 5 years after. Okay, I'm just going to stop for a second just to have a look at some of these questions. So it says, what happens if a new immunisation is added to the schedule, but there were patients in the day before and didn't receive that immunisation, e.g. additions to the 4-year-old for meningococcal? Generally, each addition or change to the schedule will give you directions on what the catch-up is and the age for those catch-ups. So, you know, for instance, when we added the Zostavax, that was for 70 years and onwards, and it has a limited catch-up until 2021, which is coming up. So we do give directions, but unfortunately, if somebody's already received the vaccine and paid for that privately before it was added to the schedule, unless whichever the vaccine is, the recommendation is that they to have another one, they wouldn't. They just unfortunately miss out. You can't back time it. Like if somebody was born, you know, when we brought the Zostavax vaccine in, there were a lot of people that missed out because of the changes to the schedule. They'd already received a Zostavax vaccine, and unfortunately the recommendations are to have a second one. So unfortunately, it comes down to timing sometimes. So the other question is, vaccine efficacy is questionable in older persons, and why are we giving Prevnar 13 to everyone over the age of 70? So I'm not sure where that information on the vaccine efficacy comes from. INSEARS, the National Centre for Immunisation Research and Surveillance, have published information on the pneumococcal changes and why the decision was made, and the evidence shows that it is immunogenic in older people, more immunogenic than the Pneumovax 23. The Pneumovax 23 is a polysaccharide vaccine. Prevnar 13 is a conjugate vaccine. Conjugate vaccines by nature are more immunogenic, they are longer lasting and elicit a more pronounced immune response. So that's why it was changed over, because it's providing an added protection, more protection than the Pneumovax 23 does. You mentioned you had to have a Medicare eligibility to receive free NIP. I work in a school and we have non-Australian resident students who participate in the school immunisation program. So yes, that's correct. We, in the school immunisation program, it is a mass program. In Northern Sydney alone, we have over 20,000 kids that we vaccinate. We don't quibble about whether they're entitled to a free vaccine or not. It benefits all of us for them to be vaccinated. So technically, they probably wouldn't be entitled to a vaccine, but by being in our schools, they certainly get given it, and we're not concerned about that at all. All right, so I'll move on to the get back to the presentation. So anyone over 12 months of age with a at-risk medical condition will receive Prevnar 13 at diagnosis, and then they get those 2 lifetime-only Pneumovax 23. The first one is 2 to 12 months after that Prevnar 13, so 8 weeks, minimum of 8 weeks after. So ideally 2 to 12 months later they get it, or at 4 years and over, whichever's later. I say ideally because we never restart a vaccination program. So if you had a parent who they received that Prevnar 13 at diagnosis, but then they didn't come back for another 4 years to get the Pneumovax 23, you would still just give them the Pneumovax 23. You wouldn't have to worry about revaccinating them for the Prevnar 13. And then they have an additional dose of Pneumovax 23 at least 5 years later. There's catch-up tables in the handbook, and there's always us to call if you need any clarification around anything. Aboriginal people aged 50 years and over without medical risk factors. So that has changed. They get Prevnar 13 now at 50 years of age. Before it was they had the 2 Pneumovaxes only. So now at 50 years of age, they get Prevnar 13. And then 2 to 12 months later, they get the Pneumovax 23. And then a minimum of 5 years after that first dose of Pneumovax 23, they have their second and final Pneumovax 23. If they've previously received a Pneumovax 23, you still give them the Prevnar 13. You do need to wait, excuse me, you do need to wait 12 months after giving the Pneumovax 23. So the interval, if you give Prevnar 13 first, is 8 weeks before you give Pneumovax. But if Pneumovax 23 was given first, then it's a 12-month interval to wait for the Pneumovax vaccine. So if the second dose is required, give the final dose of Pneumovax 23 at 12 months after the Prevnar and 5 years after the previous dose of Pneumovax 23, whichever's later. And I'm just having another little squiz at the questions. Hep B given as a baby, now 18, not showing immunity. Can you remind me of the advice? 1, repeat vaccine, then test 4 to 8 weeks later, or revaccinate with the 3 doses. So if you've got a documented dose of hepatitis B, you don't need to restart the program. So the key is having a documented dose. It's not unusual for people to show less than 10 antibodies on testing, especially when a long time has passed since they had the vaccination. Doesn't mean that they're not immune. Their antibodies have just waned on testing. So what we want to do is stimulate an immune response. So the advice is to give them a booster dose. If they're not in a high-risk group, so they're not a healthcare worker, or they're not somebody who's at high risk of contracting hepatitis B, you'd leave it at that. You don't need to retest them. We don't recommend doing routine serological, post-vaccination serological testing. However, if it's somebody who is at high risk, you then could redo the testing, and you'd probably see that they've had, in most cases, they've had a strong immune response, and their antibodies are well over 10. So that's a normal thing to have that waning on testing, which is why we tend not to rely on serological evidence for immunity post-vaccination. Is this type of at-risk children have received 2 pneumococcal in their early age? Shall we give them pneumococcal 23? No. So it's two lifetime doses of pneumococcal. So if you think, the schedule will change 200 times over between now and when they turn 70, but they've had their primary dose of Prevnar. They've had their 2 Pneumovax 23. When they get to that age, if the recommendations were still the same as they are, they would just get that Prevnar 13, and that would be it. There's no more Pneumovax 23 recommended. And you may be aware that, or familiar with some patients who've had more than 3 doses, can have quite severe reactions. So it's not quite severe injection site reactions, abscess and quite bad infections at the site, and that's another reason why we limit those doses. Okay, so just moving back to the presentation. So for individuals over 70 years and over that have no risk factors, so these are the people that you were vaccinating with Pneumovax 23 at 65 years of age. The changes are now Prevnar 13 and only Prevnar 13, not till 70 years of age and over. And the change in that age group was around epidemiological evidence of the biggest burden and the severity of disease are in those age groups. So that's why the decision was made to move it to 70 years. And it's Prevnar only and no Pneumovax 23. There's no time limited catch up for it. So if you've got somebody who rocks up in 10 years time and hasn't had their Prevnar 13, please give them that Prevnar 13. So anyone who turned 70 from the 1st of July 2020 are eligible for that funded dose. If they've already received a funded dose of Pneumovax 23 at 65, still give them that Prevnar 13, but just remember you need to leave 12 months between the doses. Okay. Got lots of questions coming through, so I might just move on with the presentation and I'll have another review in a little bit. Okay, so this is the pneumococcal decision tree, which is I'll just make sure I haven't skipped a slide, hang on a second. Yeah, so this is a pneumococcal decision tree, which is a really handy resource to have. It includes the decision tree around what vaccination you would be giving for in certain scenarios, and then it also has that table which I had before, which lists all the risk medical conditions and whether or not they are funded, whether or not the doses are funded. All right, so I've got another poll. Let's see if I can manage it. What immunisation should a patient who turns 70 on the 15th of July 2020 receive? And I'll pop that up now, and I'll give you about 20 seconds or so if everybody would want to chime in and start answering those questions, and then I'll reveal everything. And I'll just have a read of these questions while you're doing that. All right, so we've got pretty even splits on two of those questions. So it's the first one's starting to pull out in front. All right, so I'm going to end polling now. The majority of people went for the first response, which is influenza for over 65 vaccine, the pneumococcal Prevnar 13 and Zostavax. So that's correct. The majority of you have got that right, which is great. So oops, sorry, I'm having some technical difficulties, bear with me. So influenza, pneumococcal and zoster. It's pretty straightforward. Obviously influenza, if there's an influenza vaccine available, we're in influenza season, but definitely those are the three vaccines that age group should be offered. Okay, so moving on to the meningococcal recommendation. Actually, before I do, I'm going to answer a couple of questions because they're building up a bit. Okay, so can children under 10 years old without a Medicare card have catch-up vaccine for free? For example, they're moving from overseas with a parent. So as I said, the technical eligibility for funded vaccines are based on their having Medicare. However, for under 10-year-olds, we are happy for them to be vaccinated. If that means them getting a free funded vaccine, then that's great, because we as a population benefit from as many kids being vaccinated as possible, so we don't quibble over the under 10-year-olds. Why is it recommended to wait 2 to 12 months between Prevnar 13 and then Pneumovax 23 and 12 months if it's reversed? So it's got to do with the conjugate versus polysaccharide vaccine and the order that you give it in. So they're two different vaccines and have been they're with different formulations and manufacturing processes. So if you give a conjugate first, then it's only 2-month wait, 8-week wait. But if you give a polysaccharide first, you have to wait a year. And the reason is that it will affect the immunogenicity of that vaccine. So if there's been a previous bad local reaction to Pneumovax 23, is it okay to still go ahead with Prevnar 13 at age 70? Yes, yes it is. That was a quick and easy one. Okay, so meningococcal B, For Aboriginal children, you'll know that we've added Bexsero to the schedule. So that's the meningococcal B vaccine used for, well, it's the only meningococcal B vaccine for that age group on the market. So that's now included for Aboriginal Torres Strait Islander children at 6 weeks, 4 months and 12 months of age. So catch-up's funded for kids under 2 until 30th of June 2023. So while from 1st of July, we're giving children showing up at their 6 week, 4 month and 12 month schedule point, Aboriginal children, meningococcal B, the catch-up is funded up to 2 years. So if you've got a 18-month-old who's presenting now wanting to be vaccinated for meningococcal B and they're Aboriginal Torres Strait Islander, then you can do that up until June 2023. Prophylactic paracetamol is still recommended for all children under 2 years of age prior to administration of meningococcal B and for 12 hours after administration, and that's because the elevated risk of fever following that vaccine, and in particular when given in conjunction with the usual NIP vaccine. So it's really important to remember, if you have Aboriginal children and you're giving them a meningococcal B vaccine, that they're getting that paracetamol prophylaxis. It's not a vaccine that's required to receive family benefits. So if somebody elects not to get it, they can, and it won't affect their ability to be able to enroll in childcare or receive family benefits. There are additional doses required for certain risk medical conditions, asplenia, hyposplenia, complement deficiency, treatment with eculizumab, HIV and hematopoietic stem cell transplants are all requiring additional doses, which you can find more information in the handbook. Yeah, but those are funded too. Only these risk medical conditions are funded, sorry. So the asplenia, hyposplenia, complement deficiency, and treatment with eculizumab. I can never pronounce that. So those are funded. All other medical conditions, and there are quite a few of them where meningococcal B is recommended, aren't funded. So just refer back to that table that I showed you before, where it lists what is and isn't funded. It's still recommended for people with HIV or hematopoietic stem cell transplants, but it isn't funded unless they're Aboriginal Torres Strait Islander and under the age of 2. Meningococcal ACWY, the Nimenrix, that is for, so we've always offered that. There's nothing new here. It's around the funding. So previously they weren't funded and now they are, which is great. So, but only for these risk medical conditions, which is asplenia, hyposplenia, complement deficiency, and treatment with eculizumab. So yeah, again, refer to the immunisation handbook because it depends on their age, their current age, and what their medical condition is. Haemophilus influenza type B is also now funded. So it has always been recommended for people with asplenia and hyposplenia, but it's now funded. So a single dose is required, and no booster doses are needed. Okay, so just popping, so those are the main changes to the schedule. And now I just want to have a quick reminder about cold chain, very quick. So just a reminder that when you're ordering your vaccines, you are completing a declaration which states that you have these things in place at the vaccine, at your location. So in order to be able to order vaccines, you're declaring that yes to all of these. That includes that you have a vaccine specific fridge, and it includes that at least one staff member at your location has done the New South Wales Health Vaccine Storage and Cold Chain Management training module. That is a requirement for one person to do it. If you're an authorised nurse immuniser, this is the link for the training. If you're an authorised nurse immuniser, you should be doing that annually, but I would recommend that anyone involved in cold chain does this annually. It's about 45-minute online module. It gives you a certificate at the end of it and you get CPD points for it, and it's a really important thing to ensure that you're storing your vaccines properly. So on that note, another thing I just wanted to remind you of, there have been some issues with storage, proper storage with vaccines recently, where some practices have decanted, so taken the vaccines out of their boxes. I just wanted to remind you that vaccines are very sensitive, not just to cold and heat, but also to light, any UV light, and that includes office lighting. You should not be taking your vaccines out of their packets. And it seems the biggest catalyst for this is influenza. Lots of people are storing large amounts of influenza vaccines, and to accommodate them in their fridges are taking them out of their boxes. Please don't do that. If you have issues with your storage, you need to be ordering smaller amounts more frequently, or you may need to look at increasing the size of your vaccine storage to accommodate your influenza vaccines. But definitely, please don't take them out. The advice has been so far to revaccinate patients who have been vaccinated with light affected vaccines, because that we want to make sure we're giving them vaccines that are potent and effective. And if we're compromising them with cold and heat issues and light issues as well, then we're not doing that. So it's just really important to make sure your fridge doesn't look like this, basically, that it's neatly ordered and lots of room to be able to allow for air circulation, and you've not got things pressed up against the sides of the fridge, and things aren't out of boxes. All right, so another question coming up. A mother brought her 5-week and 6-day-old baby in to get her 6 weeks vaccinations. Can you give them early? And I'll get you all to just respond to that one for me. I'm not going to keep this one open too long, because I expect everybody knows the answer to this at this point. But if you don't, I don't know. So feel free to answer however you think best fits. And I'll just have a quick squiz at the questions. It says, is it correct that adults with Down syndrome are no longer funded for pneumococcal vaccines? I don't think they ever were off the top of my head, but I would need to look into that one. But no, they don't come under the risk medical conditions. Is that Aboriginal children outside of New South Wales? No, that's all Aboriginal children. That's for meningococcal B, I presume that question was. So all Aboriginal children in Australia are entitled to a meningococcal B vaccine. Full vaccine at once, does this increase any side effects? Well, not that I'm aware of. I mean, it's always difficult to provide 4 vaccines at once. However, we monitor and survey vaccines. So I'm just going to close that poll while I'm rambling on. We monitor them, so we keep an eye on any increased reactions, and I'm not aware of it being an increased issue. They're still getting, you would still expect the same generalised localised reactions as per the advice sheet that you hand parents when you're giving them their vaccinations. But with the additional vaccines, I don't think there is any increase with side effects. We've been doing that a lot. We have refugee children that get many vaccines at once, and it hasn't been an issue in the past. Okay, so the answer to that poll, the majority of people got that right. The answer is no, you never bring them forward. As much as you'd like to, and it's only a day early, you never bring it forward. The reason being that it's not registered. It's not, you're giving a vaccination off license if you're giving it to somebody under 6 weeks of age. So you always, if somebody's been incorrectly scheduled and come in a little bit early, unfortunately, you have to send them away. You need them to come back when they're over 6 weeks of age. Travelling overseas isn't a reason to vaccinate early. The advice would be to the parents, they shouldn't be travelling with a child that young, But if they are, they need to, and they want them to be vaccinated, they have to come at 6 weeks of age. We don't do it any earlier. Okay, so moving on, we're up to the preventable diseases section. And there's some very topical issues with that of late, and I'm sure you're interested to see what's been going on. So I still have to recap hepatitis B, and this one comes up all the time, but it's a really important one. It still causes a significant amount of morbidity and mortality in the world. You know, in the world, more than 350 million people have chronic infection. It's estimated to have caused more than a third of the world's population have been infected with hepatitis B at some point. Causes more than 1 million deaths worldwide every year. In New South Wales, we see probably about 2,000 new cases, between 2,500 cases annually. And in Australia, we have over 230,000 people with chronic infection. So it's still a significant problem for us. We have not as big a problem as with other countries that don't have as comprehensive a vaccination program as we have, but still one of interest. The control strategy, we do a birth dose for all neonates. In Northern Sydney Local Health District, our vaccination rate for hepatitis B is 95%, which is fantastic. You know, we could do better, but you know, it's not mandatory. It's one that we strongly encourage parents to agree to, but a lot of parents do decline, but 95% is a fantastic rate. We give it within the first 7 days of life, preferably within 24 hours, and we don't catch it up. The reason being that after those first 7 days, maternal antibodies can interfere with the vaccine, so that's why we just don't give it beyond that point. We give it to protect against vertical transmission from mum to bub, and from horizontal from anybody in the household with the baby as well, so any infected people. It also has the benefit of priming B cell memory and getting the immune system ready for the next 3 doses. So as with any immunisation, the more you give, the more ready your immune response is. Your immune response is always quicker. So that birth dose means that at 6 weeks, that the uptake of that is a lot faster. And then they go on to have their first, second and third doses, which would all be familiar with in the Infinrix Hexa at 6 weeks, 4 months and 6 months of age. And that is in Northern Sydney. Our rate for hepatitis B at 12 months of age is 96.5%, which is great. That's all the hard work that you guys are doing out there in GP practice and council clinics. To do such a good job of having such a good rate for hepatitis B. For positive mums, so mums who are hepatitis B antigen positive, babies are also given immunoglobulin, and that's given within the first 12 hours of birth, and they also get the vaccine. And in Northern Sydney, that is a 100% uptake. I want to say uptake, but that is, we have 99.9% of parents will want the immunoglobulin, but we have had cases in the past where parents have refused, and it has actually gone to court and they were instructed that they had to give it. So we do have a 100% uptake with that, and it's really important for the prevention of hepatitis B in these vulnerable kids. They have the schedule as per usual, and then we follow them up at the public health unit, the mums, just to have a chat to them about the importance of vaccination, getting them on time, and also doing hepatitis B antigen and antibody serological testing at 12 months of age. It's 3 to 12 months after vaccination, so once the final vaccination has been given, but we always just say at 12 months of age, talk to your GP about getting the baby tested for hepatitis B antibodies and antigens. We don't do it before 9 months of age because of the birth dose of immunoglobulin that can affect that result. So the reason that we provide this early protection, that's one thing that comes up quite frequently, is with parents is, why are we vaccinating these kids so early? The main reason is that, in short, the younger you are when you're infected, the more likely you are that you'll develop chronic infection and advanced liver disease. So, for example, adults, when they're infected, they're more likely to be symptomatic, but only up to 50% are symptomatic. Kids infected as infants are usually asymptomatic, so we don't have a clinical picture that they're likely to be infected, so they remain untreated for longer times. With adults, they usually recover without treatment. They will develop immunity and then not go on to develop any further complications. Whereas if you're infected as an infant, your infection is usually persistent and much more likely to develop a chronic infection. So for adults, it's only 5 to 10% of them will develop chronic infection. For infants, 90% of them, and for children, 30% of them. So the younger you are, the more detrimental this is. So it's really important to make sure that we're protecting these kids. Okay, so before I move on to whooping cough, I'm just going to have a quick scan through some more questions. There's a lot.
Some questions in chat too, Sally.
Okay. I'll just have a... Yeah, what I might do, if you'll forgive me, is I'm just going to persevere through the talk and then I'll answer the questions at the end. Okay, so pertussis caused by bacteria. People are usually infectious for 3 weeks after their symptoms begin, or for 5 days on antibiotics. So once they've had antibiotics for 5 days, they're no longer infectious. We see peaks every 3 to 4 years in Australia. Infants under 6 months of old are at the greatest risk, and it's much more under-recognised and under-reported in adults and older children. Our control strategies, we do primary vaccination at 6 weeks, 4 months and 6 months. And then there are booster doses at 18 months, 4 years, and in adolescents. We do maternal diphtheria, tetanus, pertussis vaccination, and we vaccinate adults at risk every 10 years. So those are people like healthcare workers. Feel free to interrupt me if there's any questions that you think need to be raised now. So these are the pertussis notifications, and unfortunately my data, where I get my data source from New South Wales Health, those web pages have gone down and are down for a few weeks. So my data only goes back to March, that's the most recent, but you know, life as we all know it essentially stopped around then. So that's essentially what's happened with most of the infectious diseases. So you can see this is just a good demonstration. This graph shows you the black line shows you the 5 years and older. The blue line shows you the less than 5 years. So you can see that those peaks that we see every 3 to 4 years. This large peak in 2015 was before we introduced the 18-month and maternal pertussis vaccinations. This peak that we saw around that time we would expect at that 3 to 4 year mark in 2018 is a lot smaller, which is promising. So hopefully we see peaks like this much smaller than we've seen in the past, thanks to the strategies that we have implemented. These are the age groups for pertussis. You can see they're overrepresented in the young people, and that's because they're much more easier to diagnose and therefore we suspect and therefore test. These older age groups still have pertussis. They're still at as higher risk of contracting and transmitting pertussis as these younger groups. However, they're not as sick and often don't seek medical treatment, aren't as suspicious of pertussis infection, so don't get tested as much, and therefore they're underrepresented on laboratory testing. Okay, so just moving on to measles. It's a highly contagious viral illness we'd all be familiar with. The common complications are otitis media, pneumonia and bronchitis. We see severe complications in 1 to 3 children in 1,000, and it can be fatal. It's estimated to cause 2.6 million deaths a year before there was a vaccine available. It's so contagious that, you know, essentially everybody had it before there was a vaccine. Since we've had a vaccine, we see about 142,000 deaths in 2018, and that's mostly in children under 5 years of age. So it's fantastic that we have vaccines available to us. The challenge is getting them to those populations. In Australia, we were declared measles free in 2018, and almost all cases that we see are imported from overseas. Children aged less than 12 months and Australians in their 20s and to early 50s are at greater risk. And the reason for that under 12 months of age, we don't vaccinate. So we vaccinate from 12 months of age. And people in their 20s to early 50s were born in that time frame when we were giving measles vaccination, but we were only giving one. Initially, we only gave one. So the efficacy of the vaccine, I think, is around 95 to 97% effective after one dose. And after 2 doses, it's almost 100%. It's about 99.9% effective. So those people that only receive 1 dose, there is a proportion of the community that are still vulnerable. And we do still see infection in those people. In 2019, there were 59 cases in New South Wales. So we were having a bit of an outbreak last year. You may remember before COVID decided to change our lives, that measles was the hot topic. And there was a global outbreak and we were seeing the repercussions of that. We saw in 2020, in January and February, 11 cases. And then since March, when we closed our borders, we've had no more cases of measles. So it supports the fact that we import our cases. The control strategies that we've had, it's almost entirely preventable with those 2 doses of the vaccine. We give 2 funded doses from 12 months on the NIP, and all unvaccinated people who are born after 1966, on or after 1966, get a free vaccine, and rubella seronegative postnatal women get vaccinated as well. So we don't vaccinate anyone before 1966 because those age groups weren't around when we had, the vaccine wasn't around when they were born. So almost 100% of them have natural immunity because they've been infected in the past. Early vaccination from 6 months of age in special circumstances. So when we were seeing measles outbreaks, we were advising vaccinating from 6 months of age if people were going to measles endemic countries. And that requires revaccination from 12 months when you do it that early. But that's not a standard recommendation. It's only in special circumstances. So you could do it from 6 months if we had an outbreak here in Australia or if somebody was travelling overseas. In Australia, 93.71% of 2-year-olds are vaccinated for measles, which is okay, but we really need to get to a 95% rate and above for it to be protective. These are the measles notifications up until March this year. You can see we've been seeing lots of outbreaks. In 2019, we've seen quite a few cases. And then from February, from March it ends, but I looked up the stats. We haven't had any cases. And these are the age groups that we see. So normally we see them in these younger age groups. This 65 to 69-year-olds, a bit of an anomaly. You do occasionally see them, but it's a rare occurrence. Normally it's in these younger age groups that are travelling or too young to have received the vaccine. Globally, in 2019, there was over 300% increase in measles, and all regions of the world were experiencing outbreaks. There was an outbreak in Samoa in late 2019, and a state of emergency was declared. They had over 5,000 cases and more than 80 deaths. that was related to a incident that happened with, I think it was 2 babies that were accidentally killed having received a measles, mumps, rubella vaccine through negligence. They were, the vaccines were diluted with an anaesthetic. Unfortunately, those programs were immediately suspended and for 8 months, and that suspension was enough to create a break in herd immunity and to instill mistrust in the community. So very few people were getting vaccinated, and that's why they've seen this outbreak. That's caused concurrent outbreaks in New Zealand, Tonga, American Samoa and Fiji, and we were seeing some of those as well. So in 2019, WHO estimates that only 86% of children have received their first dose of measles vaccine and only 69% their second. And those are mostly in third world countries. As I said, our rate is around 93%. But yeah, there's a lot more work that needs to be done to get these vaccines to kids. All right, so I've got another poll that I'm going to pop up. How soon before the 12-month milestone can measles, mumps and rubella? Nope, not that one. Can measles, mumps and rubella be administered? And I'll just give you a few seconds to have a look through that and answer. And I'm just going to read some of these questions. All right, I'm just going to end the polling now. Thank you everybody for participating. So the answer to that one, how soon before the 12-month milestone can MMR be administered? Yeah, I gave that one away before. 6 months of age and it needs repeating. Yeah, I probably could have worded that question a bit better. It's actually 11 months. So 11 months of age, if you gave it from 11 months of age, you don't need to repeat it. So some people did answer that one. It's safe to give from 11 months of age without needing repeating. But if you give it from 6 months, between 6 months and 11 months of age, it does need to be repeated after 12 months of age. Okay. So only bring them forward in special circumstances, as I said before, and that would be travelling and outbreak management. Okay, so I'm just going to have a little read through some of these, talk through some of these questions. Okay, so some of these questions I'll cover in my talk. So I'm just going to pick up with meningococcal. There's a few catch-up questions. I've got a catch-up section coming up, so bear with me. So meningococcal is caused by a bacteria. We see the highest incidence in the under 2s, in the 15 to 19-year-olds. There are 13 serogroups, but in Australia, our most common ones are A, B, C, W, and Y. The two most dominant strains are meningococcal B and W. So meningococcal B is most common in children, and meningococcal W is more evenly spread, but meningococcal W has a higher, almost double the case fatality rate that meningococcal B has. This is a breakdown of meningococcal disease. I might just skip on to ages. It just shows you. So the yellow line is all strains, and then it's divided into colours for each strain. So black is the B. That is the more prevalent one that we see currently. And W is that bright blue line. You can see it's not as prevalent as B. It was peaking above B for a while, but since we've been doing the ACWY program, it's come down a lot. I don't know how it's been going. I presume, like most infectious diseases, since we've all been quarantining, it's doing very well. But like I said, my stats are only up until March. A breakdown to have a look at age groups of which we see them. You can see for the meningococcal B that it's much more prevalent in those younger age groups, the 0 to 4 years of age. For meningococcal W, it's a little bit more of an even spread. There's 2 cases in the 0 to 4 years of age, and then we see an even spread across all age groups. For the Y, we see quite a few cases of the Y. It doesn't have the case fatality rate of other strains though, and we have the added benefit of protecting against the Y in the ACWY program. And I always show this slide because meningococcal C used to be the most prevalent strain that we saw in Australia, and we very rarely see it anymore. So this is a really great demonstration of how an effective immunisation program can make a huge difference. Let's hope we do that with the rest of the strains. So the strategies that we have from 2003 to 2018, we had meningococcal C conjugate vaccine at 12 months of age. So that was just men C only. And then in 2017, we brought in the 4-valent, the meningococcal ACWY program for adolescents. That's it for 15 to 19-year-olds. And then from the 1st of July 2018, we introduced it to the NIP for kids at 12 months of age. And then you know of the new addition to the schedule for Aboriginal Torres Strait Islanders and people with risk medical conditions, the meningococcal B, and the funding of the MenACWY. So just around the funding, who is it funded for? The meningococcal ACWY for children at 12 months of age, and any catch-up of children who are under 10 years of age who haven't received a meningococcal vaccine. So if a child's received a monovalent, so meningococcal C only vaccine, they don't get caught up for MenACWY. But if they've never received a meningococcal vaccine, you would give them meningococcal ACWY, not meningococcal C only. And we do it for adolescents aged 15 to 19 years of age, and that's principally delivered in our high school program. If you've got a kid that's 10 to 14 years of age, so they're in a lower risk group, they're at much less likely to catch any strain of meningococcal at 10 to 14 years of age, they are funded for catch-up for a monovalent meningococcal only. So if you had a 10 to 14-year-old, you'd give them a NESC-Vax C, so monovalent meningococcal C, and then when they're in high school at 15 to onwards, we would give them a meningococcal ACWY. Okay, so I've got another poll coming up. How soon before the 12 months milestone can Nimenrix be given without needing to be repeated? And I'll just leave that up for a few seconds and I'll get some of you to answer that for me. Okay, so we'll close that poll now. The majority of you have gone for the 11 months of age option. So that's right. We only bring it forward if we need to, so in special circumstances. But you can give it from 11 months of age without any further doses being needed. You will be aware that meningococcal ACWY can be given from 6 weeks of age. However, they always require a booster dose over the age of 12 months. But if they've received a dose from 11 months of age, then they don't need to repeat it beyond 12 months of age. All right, so moving on to COVID-19, I'm sure you've all been saturated with news of this, so I won't harp too much on it. But just a quick recap, it's caused by a new strain of coronavirus, spread from person to person by respiratory droplets. There's still a lot to learn about it. 7 months later, we're still learning a lot about it. In Australia, as of today, we had 15,582 cases and 176 deaths, which we have roughly a 1.5% crude case fatality rate. So 1.4% of people who contract COVID will die from it. Globally, we reached 17 million cases today and over 669,000 deaths. The global crude case fatality rate is at around 4.1%. So obviously the case fatality rate is much higher in third world countries and countries that don't have access to a fantastic healthcare system like we do. So we're very fortunate in Australia. Yes, we're seeing outbreaks, but nothing like the rest of the world. So having a look at the cases that we see by age group and sex, you can see that the majority of those cases, well, most of the cases are grouped into that young adult to middle age groups, people who are more likely to be travelling, to be moving about the community, socialising and working. So they're heavy transmitters. By deaths by age group and sex, you can see that it is much more heavily represented in the elderly populations. The illness is transmitted in younger populations, but their burden of disease is a lot lower. How are we going for a vaccine? I know it's not technically a vaccine progress, but we're all waiting to see when we're getting one. So I've just done a quick recap for you. This changes all the time. It's one of the most popular fields of research at the moment. So this is where we're at the moment. There are 24 vaccine candidates currently in clinical evaluation. There's lots more, but that's where we're at in actual clinical evaluations. There are 4 who've reached phase 3 trials. And those 4 vaccines are Sinovac, the Wuhan Institute of Biological Products, and the Beijing Institute of Biological Products with Sinopharm, and the University of Oxford with AstraZeneca. There are lots of other promising candidates in other phase trials, but phase 3 trials are the last thing that we have to get through before they're ready to be produced and marketed. So those are the 4 front runners. But how are each of them doing? So Sinovac is a inactivated vaccine known as Coronavac. It is a 2-dose regime given 14 days apart, and it has shown some promising results with neutralizing antibodies. Details aren't available. Initial results do show a promising safety profile. So this is based on any published research, so there's not a lot of details on this one, but they're starting phase 3 trials in Brazil, and there's no word on when that's likely to be ready. The 2 vaccines are being produced by the Beijing and Wuhan Institute of Biological Products. Those are 2 inactivated vaccines. There's not much information available on them at all. Nothing's been published, but they're claiming high levels of neutralizing antibodies after a 2-dose regime. One of the vaccines started phase 3 trials in the United Arab Emirates in June. No idea when they'll be ready, but apparently China is already giving them to state-owned employees of state-owned companies, so they must think they're pretty good. And then our final candidate, which is our most promising one, is from the University of Oxford and AstraZeneca, and they have produced a non-replicating viral vector known by the catchy name AZD1222. I hope they come up with a new name. This one is done with genetic RNA and DNA vaccine development. So it's quite new age technology that they're using, and it uses the genetic code of those spikes on the coronavirus protein. It has shown to trigger a strong immune response. So it's showing both neutralizing antibodies and T cells. So theoretically, that T cell immunity could provide longevity of protection. So they're quite positive about how this one's looking. It's recently gone to phase 3 trials in Brazil and South Africa. According to the company, they could be ready to produce this by the end of the year if it passes its trials. Because it uses different technology, it's not a inactivated vaccine, so you don't have to grow the virus and then inactivate it and then manufacture it. So it takes out a few steps in the process. So the company claimed that they are capable of producing billions of these vaccines in a short amount of time, which is good news. So just watch this page. This space changes all the time, and we're all very, very eager to get a vaccine out soon. All right, so moving on to influenza caused by a virus. Its biggest burden of disease is the under 5s and the over 80s. It causes a significant amount of annual morbidity and mortality, especially in Australians over 50 years of age. In 2019, we saw a total of 310,000 laboratory confirmed cases and over 800 influenza-associated deaths in 2019. The case fatality rate in Australia for influenza is less than, or approximately 0.1%. So it significantly causes significantly less deaths than COVID does. However, obviously we don't have the control measures in place for influenza that we are currently doing for COVID. So we're seeing a lot more deaths from COVID. A lot less deaths from COVID than we do influenza. Those 800 deaths are associated with roughly, sorry, I forgot my statistic on that one. It's, I think it was, no, I'm not going to try and guess it. It's essentially, it's a, it is highly infectious, as is COVID. However, the case fatality rate is a lot less than COVID is. So it's recommended for everybody over 6 months of age. That's regardless of their risk factors. Everybody who is aged 6 months and over should be offered a free should be offered an influenza vaccine. The only people that are entitled to a free one are those aged over 6 months and less than 5 years, 65 years and over, pregnant women at any stage of their pregnancy, Aboriginal Torres Strait Islanders, and anyone over 6 months of age with a risk medical condition. We also have the over 65 high dose formulations. This year we only use the Fluad Quad in the NIP, but those are other strategies that we've implemented to try to control influenza. This graph shows the previous influenza seasons. You can see we didn't have much of a season in 2018, but with the before and after seasons, 17 and 19 were quite difficult. You may all remember, if you can remember pre-COVID. That data doesn't have 2020 season. We're in the middle of our influenza season, but I've got some information that shows us what our influenza is doing as far as laboratory tests go. You can see the blue line is the average for previous years, and the red line is our influenza notifications this year. So our social distancing and isolation measures have been very effective at reducing the amount of influenza that we're seeing. And you can see down the bottom there is influenza outbreaks in institutions, so aged care facilities. This year in 2020, we've had 15 compared to 383 last year. So it's tracking a lot better than we normally see. You might think, well, that's probably because we're not testing for influenza, we're too busy testing for COVID, but you can see with this graph that we've actually tested more for influenza than we have in the past. So it is very indicative of a very low influenza season. The quadrivalent vaccines have the A Brisbane, the A South Australia, the B Washington, and the B Phuket. The timing of the vaccination is in most normal circumstances is recommended before the onset of the influenza season. Peak season in Australia is usually June to September, and we try to optimally time it for it to be most beneficial in the first 3 to 4 months following vaccination. But obviously things change. So this year we did it a lot earlier than we would normally do it because of the pandemic. Revaccination in the same season is not recommended. It's not contraindicated, but it's not recommended, and people shouldn't be getting more than one funded vaccine. You know, I know that often there are the over 65s that rush out, they'll get the quadrivalent to wait for the over 65 formulations to come out. It's not harmful for them to do that, however, we're not recommending it. It's never too late to vaccinate. The only time you don't vaccinate is if the vaccine has expired. These are the ATAGI guidelines, which have this table within the guidelines that have quite a succinct way of putting what vaccines are okay to give to which age group. This year was probably the least complicated influenza vaccine schedule on offer, but yes, always refer to the ATAGI guidelines. This is just a breakdown of the influenza vaccines reported to the Australian Immunisation Register from the 1st of March to the 15th of July. So obviously that's when we're all vaccinating like crazy. You can see that in total in New South Wales, there were 2,691,000 notifications to air. That was, however, 2.99 million funded doses were delivered as of the 6th of July. So that's over 500,000 doses that haven't gone on to air. So those are funded vaccines. We can't blame pharmacy for that one. Those are the only people that are entitled to give funded vaccines are hospitals, public hospitals, immunisation providers such as yourselves that have vaccine accounts. So that's anyone with a vaccine account who's ordered influenza doses. So I guess my message here is it's really important to make sure that we're remembering to get those vaccination records onto the Australian Immunisation Register. Okay, I'm going to skip polling this one and I'm just going to talk through it. So parents are taking their 3-month-old baby overseas. Can you give the 4-month vaccines early? Yes, you can, but you only bring it forward in special circumstances, so such as travel or outbreak management. You need to be mindful of the minimum intervals when you're vaccinating, and I'll go over those in the catch-up section. And also make sure that you're sticking to those Rotarix age limits. Generally speaking, AIR will consider vaccines given more than 28 days before they're due as invalid. So just remembering when you're trying to work out if you can give a vaccine early, don't give it more than 28 days before it's due. That doesn't apply to varicella though. When you're calculating, I'm moving on to catch-ups, just being mindful of the time. I'm just going to step things up a little bit. Just remember that for incomplete or overdue vaccinations, always build on the previous documented doses, never start again. Doesn't matter how long it's been, there is always that immune memory that your immune system will work on for subsequent doses. So we always just build on previous doses. If more than one vaccine's overdue, you need to give everything that's overdue now. A catch-up schedule might be required for multiple vaccinations. So just make sure you give everything that's due on that visit. Don't defer anything. It doesn't matter how many vaccines they're getting. If they're due it, you should be giving it when it's due. And just be mindful with the handbook, that is our go-to guide for information on vaccinations. Product information has some very important recommendations and information in it, but there are variations to product information. The handbook has, in every section, disease section has a variation to product information section that you can always check because there are sometimes contradictory recommendations to the product information, but it's always the ATAGI recommendation that we should be giving as best practice. When I'm going to skip through these quickly because you'll get the copy of these slides, but these are the minimum dose intervals for your catch-ups. So there's always 4 weeks between live vaccines, 4 weeks between vaccines with the same antigens. Pneumococcal, there's 1 month between doses if they're under 12 months of age, or 2 months between doses if they're over 12 months of age. Hib, there's 1 month between primary doses, or 2 months between for a booster dose. Hepatitis B, 4 weeks between dose 1 and 2, 8 weeks between dose 2 and 3, and making sure that there's 16 weeks between dose 1 and 3. Those are your 3 things that you need to remember with your intervals with Hep B. Final primary dose in infants shouldn't be given before 24 weeks of age. And the optimal intervals for a monovalent vaccine, so that's a Hep B only vaccine, are 0, 1 and 6 months. There are acceptable variations for hepatitis B, and that's for overseas schedules only. So you don't give this in Australia, but we accept this for an overseas schedule. That's a birth dose plus a dose at 1 to 2 months of age and a dose at 6 to 18 months of age. And there's the alternative adolescent program for kids aged 11 to 15 years. The vaccine age limit, so some vaccines you can't give beyond certain ages. So birth dose of Hep B, not beyond 7 days of age. Pediatric hepatitis B vaccine is up until the 20th birthday. So it's, despite its name, it can still be given up until they're 20, they turn 20. And then the adult formulation is only for 20 years onwards. Boostrix and Adacel, you should only be giving over 10 years of age, and Infinrix and Tripacel formulations are the ones for the under 10s. Priox, Tetra and Procods are only given up until the 14th birthday. So if you're giving MMR and varicella beyond the 14th birthday, they're given as separate vaccinations. There's some catch-up tools available to you now to help you with your catch-up. You'd all be familiar with the catch-up tool that we put together at Northern Sydney. If you like to be a little bit more interactive with your catch-ups, you use this table and you plot it out on your on this spreadsheet, and it just helps you plot through and work through a catch-up. However, if you prefer just to get the news, then Australian Immunisation Handbook has a new catch-up calculator. So it's the first release of this catch-up calculator. It's only, at this current iteration, is only for catch-up of under 10-year-olds. I think they'll be putting newer versions out later, which will be catch-up for all people. It's available through the handbook, and it replaces the South Australian catch-up calculator. This is what it looks like once you've put it through, you've inputted all the information. So the name of the child, their date of birth, what they've had. You can choose which whether you go by vaccine brand or whether you go by antigens, and then and it asks what they've had, and then you hit enter and it will give you a schedule of vaccines, what you give now, what you give in 4 to 8 weeks time, and then what your future appointments are. So it's a handy, easy tool to use, and it is a very quick way of getting a catch up. Please don't use the immunisation register as your catch up determination. That's not a catch up tool. Don't be guided by what it's telling you is due. Or if you don't know and you're doing a catch up and you don't have the time, please use the calculator. For over 10 years of age, we have a tool in Northern Sydney which puts all that information, all the handbook information into one place for you, and it'll tell you how many doses of each of the vaccines, how many weeks apart you need to leave between each of those vaccines. Can I bring the 18-month vaccines forward? Sometimes is the answer to that one. So in special circumstances, you can actually bring the MMRV forward. So if you gave the 12, you're giving the MMR at 12 months. Say if you had a child that came in at 14 months of age and their sibling had a case of chickenpox and you wanted to make sure they were protected for varicella, you could give that MMRV at 14 months of age, and AIR wouldn't worry about it because you can give the varicella vaccination a lot sooner than 18 months of age. Same with measles, mumps, rubella. Essentially, you only have to leave 4 weeks between their first and second doses. We don't, that's not on the schedule, and we don't recommend you bringing that forward routinely, but if you had to, if they were traveling overseas or if they'd been exposed to something, you can do them sooner. Hib and DTPA, however, should not be brought forward. They're booster doses. They've already had a primary course of DTPA. They've had a primary course of Hib. They're timed specifically to make sure that they're protected in those age groups that get breakthrough disease. So bringing it forward will make them more vulnerable down the track. So just remember, you can't bring that forward. Okay, so we're just going to talk about the high school program that this year is year 7. We do DTPA, diphtheria, tetanus, pertussis, and we do 2 doses of HPV. We do year 8 catch-up for HPV, and we're also doing some other catch-ups as well now because we had a disruption to our program, so we're trying to catch up these kids as best as possible. Year 10, we offer meningococcal ACWY, and we're doing catch up into year 11 as well next year. We have intensive English centres that get all of the above, plus we offer polio, measles, mumps, rubella, hepatitis B and varicella as well. The HPV recommendations, remembering that we're on a 2-dose schedule now, which is given at 11 to 14 years of age. So while it says 11, we aim to have it given in year 7, and that's where it's delivered in the high school program. And so if they're aged between 11 and 14, it's a 2-dose schedule. If they're over 15, it's a 3-dose schedule, like we used to do at 0, 2 and 6 months of age. And just remembering that there's only 2 doses that are funded. That 3rd dose, if they're over 15, needs to be on script. To get access to records in the school program, they are now transmitted to the Australian Immunisation Register within a week of being administered. So if you have any patients or parents that you're not sure whether they were vaccinated in the school program, you can look on air and you can find them now. And there are historical records dating back to 2004 all been uploaded there as well. Vaccinating pregnant women, we now vaccinate at 20 to 32 weeks, but ideally at 28 weeks pregnancy, in each pregnancy. This is pertussis vaccination. It doesn't matter how closely spaced they are, we vaccinate every pregnancy. It's about protecting that baby in utero. If the vaccine hasn't been given by 32 weeks gestation, then it can be given anytime up until delivery. And if it didn't occur before delivery, we recommend antenatal administration of the pertussis vaccination. Why do we do it? It's for the direct passive protection of the newborn in utero. The high levels of maternal antibodies give that temporary protection to the baby and until they're old enough to be able to complete their vaccinations at 6 weeks. It reduces the significant morbidity associated with pertussis in infants, particularly the under 3 months of age. However, it has been shown to be less effective at preventing mild disease. So it reduces the severity of disease and the likelihood of hospitalisation and infant mortality. However, it doesn't stop the contraction and transmission of disease. So for that reason, it's not thought to be likely to disrupt outbreaks of pertussis. However, it's used in conjunction with our other pertussis control strategies. How successful? It's been the most successful program we've had for reducing infant mortality and morbidity. So prior to the introduction in New South Wales, we saw approximately 1 death a year in infants under 2 months of age in relation to pertussis. Since the vaccine was introduced in 2015, there's been a decrease in cases in children under 6 months of age, and there have been no deaths in infants in New South Wales. So it's been very successful. Vaccination, influenza vaccination in pregnancy, it can, well, influenza can be life-threatening for pregnant women and their baby. Changes to the immune, heart and lung functions increase the likelihood of severe illness, and they're at a much higher risk of hospitalisation and death. Severe influenza illness increases the chance of premature birth and low birth weight. We're trying to protect mum against influenza and the complications resulting from it, and also the newborns and babies aged less than 6 months, because they can't be vaccinated until they're 6 months of age. They're much more likely to be hospitalised with influenza than any other age group, so it's really important that we're protecting them. It's estimated to reduce the risk of influenza by approximately 50% in this age group. Timing of vaccination, it can be given at any time in pregnancy and give as early as possible. Best given before the onset of the flu season, but if there's a flu vaccine available and your patient has come in and are newly pregnant, you would give them the vaccine right away. You can give more than one flu vaccine if the pregnancy spans 2 flu seasons. So you don't, unlike the pertussis vaccination, there's no best time to give it other than as soon as you're aware that your patient's pregnant and there's a flu vaccine available. So if you had somebody who was pregnant late in one flu season and still pregnant for another flu season, you would give them 2 vaccines, one for each of those flu seasons. Can be given at the same time as the pertussis vaccine, but don't wait for it. Can you still give the 4 years immunisation as early as 3.5 years? The answer to that, in short, is no. So we used to give the 4-year vaccines early because we used to have breakthrough pertussis, so we were recommending it could be given from 3.5 years. But now we do the 18-month booster dose. We don't need to do that. So the 4-year-old vaccines should only be given from 4 years and onwards. They're booster doses. There's no need to bring them forward. Okay, so vaccinating of adults. Sorry, I've gone a bit over. I'm just going to work through this. Please stay with me. I'm happy to keep talking, and apologies for going over. So with adults, just always remember the HALO principle. So you're considering their health, their age, their lifestyle, and their occupation. Do they have risk medical conditions? Are they of an age that they require certain vaccinations? Do they travel? Do they live in aged care? What's their occupation? And also their cultural background. Are they a refugee? Are they Aboriginal Torres Strait Islanders? Just those are the things that you need to keep in mind when you're determining their vaccination requirements. National Centre for Immunisation Research and Surveillance have a resource tool that they've put out, which has a very handy guide for what vaccines are recommended in all age groups. So I recommend having a look at that. People with occupational risks, really important to be mindful of what a person does for a living and what vaccine preventable diseases places them at an increased risk. People who travel, people who work with animals, kids, people that work in occupations that may expose them to blood or body fluids. Healthcare worker vaccination, this has been updated. So this policy has been around for quite a while, but it has had a recent update in May this year. Just to recap, that covers diphtheria, tetanus, pertussis, hepatitis B, measles, mumps, rubella, varicella, influenza, and tuberculosis screening. The policy updates in 2018, they brought in a new category A high risk that had mandatory influenza vaccination associated with it. And there was also the allowance of a hepatitis B vaccination declaration. So we used to require either evidence of vaccination or revaccination. Now people can sign a declaration saying that they've been vaccinated if they give a good history. In 2020, we've removed the requirement that students are assessed for tuberculosis compliance within 4 months of their first clinical placement. Mandatory influenza vaccination requirements were added for workers at multi-purpose services and state government aged care facilities. They've enhanced the TB control measures, and there's the inclusion of additional documents that can be used to demonstrate compliance. It's quite a comprehensive document. which you can get all your information from that link below. But there is a table, reference table, which is essentially a checklist. So if you have a healthcare worker that comes in and wants to get pre-employment vaccination, this is what they need. They need to have had diphtheria, tetanus, pertussis, at least 1 dose within the last 10 years. And ADT is not acceptable, and yes, it needs to be a documented dose within the last 10 years. For hepatitis B, an age-appropriate course and evidence of immunity on serological testing, or documented evidence of hepatitis B core antibodies and antigens, so indicating a past infection from hepatitis B. Measles, mumps, rubella, they have to have 2 documented doses at least a month apart, or evidence of immunity on serological testing. They don't need both. If you have a patient who's had 2 documented doses, that's all you need to worry about. Please don't do serological testing in that instance. But if you don't have documented evidence, but they're pretty sure they had it done, you can do the serological testing then. And then if they were born before 1966, you don't need either of those. A birth date before 1966 is all they need. Varicella, they have to have an age-appropriate course. So if they were under 14 years, 1 dose. If they were over 14 years when they were vaccinated, then 2 doses, at least a month apart. Or same with MMR, you can test for immunity, but if you have documented doses, you don't need to. There is also the Australian Immunisation History Statement that says they have natural immunity. So a health professional would have had to have indicated on air that they had prior infection. And influenza, it's an annual vaccination. Highly mandatory for Category A high-risk areas, highly recommended for all Category A workers. And then there's a tuberculosis screening tool. Anyway, if you're working occupational health or you have a patient that is pre-employment, you can get your information from that policy document. Good news is we're getting towards the end. So what other changes are there? What else is new? There's the Australian Immunisation Handbook app. If you're not aware, I highly recommend downloading this. It's available on all devices, Android and other, as well as iPads. It allows you to be able to have the handbook offline. So the online handbook, it can't be downloaded. It can't be in entirety. This allows you to be able to have it available to you at all times. And it's very easy to use and very similar format to the online version. There is a sharing knowledge about immunisation e-learning module. So this is a 90-minute module that's been developed for healthcare professionals, and it assists with avoiding extended or confrontational interactions with patients. So anyone who's a vaccination hesitant or has questions about vaccination, and it helps providers address parents' questions and concerns. It's got recommendations for structuring vaccination consultations and tips from experienced clinicians. So it's a good one to have a look at. Vaccine supply by pharmacists in New South Wales. We've been doing this for a while. They currently are authorised to supply and administer without a prescription MMR DTPA from 16 years of age and influenza from 10 years of age. So that's privately funded vaccines. Federal government recently announced that they've agreed to expand the authority and allow them to give NIP funded vaccines. And that's pending state and territory approval, but the Commonwealth has supported pharmacist use and access of NIP vaccines. They essentially want access to all NIP vaccines with the exception of early childhood vaccinations. So watch this space. That is definitely developing. It will depend on what happens in our state. INSEARS, the National Centre, did a review of pharmacist vaccination, and they've found that they most commonly administer influenza vaccines, and most commonly in regional areas and to 50 to 64-year-olds. So it's shown that it provides access for people who normally struggle to get access, especially in regional areas. And it has identified some gaps in reporting to the Australian Immunisation Register. So apparently over 2 million privately funded influenza vaccinations were given by pharmacists in 2019, but only a quarter of them were recorded on air. So they are supposed to be uploading these records to air. It's a requirement for them to be able to vaccinate. And that's a work in progress for us to make sure that they're doing that. And that is essentially it. There's some resources just to quickly go through, and I'll answer some questions at the end for anyone who wants to hang around. So this is a resource put out by another primary health network around vaccinating. I think I saw a question about where you should be vaccinating. This is a handy chart that shows you recommended sites for vaccinating kids according to our childhood schedule. There's the National Centre for Immunisation Research and Surveillance websites. They've got a huge amount of resources there. Any questions you have around NIP changes, they've got lots of fact sheets and FAQs. They also have a specialist immunisation service that you can access if you have any patients with previous issues immunising. They may have had adverse events, or they may have complex medical histories and you're not sure. There is a number that you can ring and clinics you can refer them to. There's the Australian Immunisation Handbook, the Immunisation for Health Practitioners course run by the College of Nursing, very good course to do for immunisation providers. And there are free online courses by Queensland Health, and they total about 15 hours worth of education on immunisation. Questions about vaccination, you can download hard copies, order hard copies. And there is the Science of Immunisation website, which has some great resources, as well as the Science of Immunisation book, which is really great for patients. And there is the Australian Government website for immunisation and the Public Health Unit website. Thank you everybody for staying with me, and I'm just going to have a scroll through these questions.
Just for those that have to go on,
yep.
And then I'll come back
to
you.
Just handing me off.
Hi everyone, just for those that do need to leave now, that is fine. Sally has kindly offered to answer some questions for the next 10 minutes. If you do need to leave at this stage, thank you for joining us. And just a reminder to fill in the evaluation form either at the end when we log off, or if you do need to go now, we will send you a link tomorrow. We will also send an evaluation link to those that phoned in tonight. Certificates will be sent out within 2 weeks, and that will include a copy of the slides. So look out for that. It'll be within the next 2 weeks. And yes, the slides will come with that certificate. So I'll just pop you back on to Sally now for those who did want to stay for the Q&A session. And we'll do that for around the next 10 minutes. Thanks very much.
Okay, all right, so there's quite a few questions, so I'm going to pick and choose. Okay, so I think I've answered a few of these. Is catch-up vaccines free also for those who are the children of the parents who are on a student visa? Because often they are under 10 and many ACWI is on catch-up for that age group. Interestingly, it's not free for someone who has received MenC at 12 months. That's correct. It's not free for anyone who's received meningococcal C at 12 months, and that includes the Australian population. So meningococcal ACWI is only free if they've never received a meningococcal C vaccine before. And the answer to that would be yes, if they're under 10, they can have the free vaccine. Can MMR be given 1 to 2 days before 12 months? That's already been answered. It can be given from 11 months of age. When should the second dose of MMR be given if it was given early? So that is to be given 1 month after the last dose or from 12 months of age, whichever is later. What is the current recommendation regarding influenza immunisation? Should we give a second dose to vulnerable patients? There's no recommendation currently to give more than 1 dose in a season. So while it is most protective 3 to 4 months, we start to see immunity waning, it is still considered protective for the entire flu season. So there is no recommendations to give more than 1 dose. Children who receive meningitis vaccine 3 days before 12 months of age, is that a valid vaccine as it is accepted by AIR? Do they need repeating? So as I've mentioned before, you can give Nimenrix from 11 months of age without it needing to be repeated. So all these questions around the free vaccine, just refer back to my previous advice, is that if they have Medicare, they can get a free vaccine. If they're entitled to Medicare benefits, they can get a free vaccine. We relax that for the under 10s, but for anyone over 10, they need to be entitled to Medicare benefits. Same again for the flu vaccination, where there's only 1 recommended dose. If a patient has got the quadrivalent and then come for their free 65, it's not harmful to give it to them. However, they need to be advised that it's not recommended. No, there is no flu vaccination brand that cannot be given to pregnant women. So a student undetectable levels of antibodies after a booster hepatitis B vaccine and even after repeated vaccination. They could be a persistent non-responder. So your advice is that you give that they've had a primary course and you do post-vaccination serology 4 weeks after a primary course. This is only for risk people and healthcare workers. If they haven't seroconverted, then you give them a booster dose and then wait 4 weeks and retest. And if that hasn't caused seroconversion, then there are further booster doses required. There's also the option to do transdermal hepatitis B vaccination, which has been shown to seroconvert, have much higher rates of seroconversion after it. But give us a ring and we can go through all of that with you. Can you give Bexsero with the first immunisation if the baby is over 8 weeks? I'm not quite sure what you're asking there, but Bexsero can be given from 6 weeks of age. If overseas hepatitis B, there is a birth dose and 1 month later and 20 months later, is it valid? No, it has to fall within those age ranges to be a valid dose that I mentioned previously. No, Bexsero is not contraindicated with Prevnar 13. Bexsero can be given with all of the NIP vaccines. And just a reminder, Bexsero, however, is only funded for Aboriginal Torres Strait Islander children. What's the minimum interval for Boostrix in a pregnant woman? A patient had a Boostrix for a friend's baby in December and is now. So as long as they weren't pregnant when they had that initial dose in December 2019, then you would give them their their maternal pertussis vaccination. Ideally, we say 20 to 32 weeks. We aim for 28. If you've had somebody who's had a Boostrix vaccine quite close to their pregnancy, then you could try to time it a little bit later, but then you also don't want to risk, if they go into premature birth, missing out on that vaccine. A few parents have been told their children should have a second varicella vaccine. So yes, that is a recommendation, and that has been a recommendation in the handbook for a long time. It's just not funded. That's the difference. And there's some confusion about the importance of a vaccine because it's not funded. It is shown to be very effective at reducing the risk of breakthrough illness. 1 dose is good, 2 doses is better, but under 14 years of age, we only fund 1 and we only ask for 1 when we're asking for evidence of vaccination. But if a parent is in a position to be able to pay for a private vaccine and they're keen to make sure their kids aren't going to get breakthrough illness, then absolutely give them that second dose 4 weeks apart. HPV vaccination for a 50-year-old who has already been infected with HPV at 18 years of age. There's more than 1 strain that the HPV vaccination protects against. However, at 50 years of age, the risk of having been exposed to those strains is much higher than a younger person. So, it's done on a risk assessed basis. It's less likely to be of benefit for a 50-year-old than it is for somebody who hasn't had their sexual debut. Yes, we are still recommending that close contacts of a baby have Boostrix. All the strategies that we have are very important in the reduction of pertussis circulating in the community. So the maternal pertussis vaccination is great, but it's only one strategy. Immunity wanes from that. And as I said in my previous slides, it doesn't protect against mild illness. So it's still really important that everybody that's around those newborns are getting up-to-date pertussis vaccination. If a patient received Pneumovax at age 65, yes, they would still get the Prevnar 13. So that was covered earlier. So if occupational screening was back in 2009, do they require another serology test? No, past documents are fine. They don't need repeated. As long as they've got documented vaccination and documented seroconversion, they just need to hang on to that for the rest of their lives. Nothing more will be required. Can we mix Hib and DTP vaccine to give as 1 injection? No. So if you're talking the Hibrix and the Infanrix, no, you would give them as 2 separate injections. Prevnar, I don't know what that is. No. I think some people are answering my questions for me. Thank you. So that's all of the questions. Is there anything in chat that I needed to be aware of? I can't see the chat window.
I'll open up. There's a few questions there. Sorry. Just going to stop sharing the screen. Sorry, we're just having a look to see if there's any questions in chat too.
Thank you. Okay. We haven't received our new schedule posters. We are at the cottage. Okay, so I don't know why you haven't received your new schedule posters. They were sent out to everybody. I don't actually have any. There is. I'll find out. I'll see if there is anywhere. Actually, you might be able to get them from Better Health, I'm thinking. Anyway, leave it with me. I will find out where you can order some from. Is Prevnar 13 still recommended to those who already received 3? Yes, we've answered that one. So if they've had Pneumovax before and they're now 70, you would give them Prevnar 13. As long as, yes, there's 12 months since they had their Pneumovax. Stats for lifetime coverage of pneumococcal vaccines started as a child. I don't know. We don't know how long pneumococcal vaccination's been around, but not long enough to have information on how the longevity of protection that's offered by it. And I certainly don't know that off the top of my head, but yeah, in short, I don't know. And I don't know that we have that information yet. Catch up, vaccines free for those who are children. I answered that one. And that one. The child is from India and they have 3 doses of Hep B and one of them was given at birth. Do they need another dose? Well, that just depends on whether or not they had it at those ages that I mentioned previously. The birth dose, and I've blanked out, I can't remember what the actual ages are, but there's birth dose plus 6, yeah, look, I'm not going to try to guess it for you, but it's in my slides. They have to fall within those age groups. Do all healthcare workers get government-funded whooping cough vaccination every 10 years? If they're employed by New South Wales Health, yes. So they are entitled to free vaccination being employed by New South Wales Health. However, if you work in private practice, then it would be up to your employer as to whether or not they paid for it for you. No, I don't know when Shingrix will be available in Australia. I think it's been registered, but I haven't heard anything about it coming out. Yes, you get a copy of the slides. So if you're checking your staff's hepatitis B immune status, if that hasn't been checked before, then yes, you should. All healthcare workers should have a documented evidence of vaccination and evidence of immunity. So if they haven't had serology done, then you should be checking it and then acting appropriately based on the results. So if they're immune, great. If they're not immune, as I said before, they probably just need that one booster dose, which will stimulate an immune response, and you'll see on serology testing seroconversion 4 weeks later. So we see lots of people asking for pertussis vaccinations if they're going to be a close contact of a newborn. If they've been vaccinated in the last 10 years, is there any evidence for repeat vaccination? Well, it depends on your definition of evidence. The recommendations are still saying 1 vaccination every 10 years. However, we do know that immunity wanes, starts waning from 2 years following the vaccination, and it rapidly wanes from 5 years after. But the recommendations still state that every 10 years is okay. So I tend to advise, when that question comes up, I'll tend to advise the individual that that's the evidence that we have, and leave it up to them to decide if they want to have it earlier than those 10 years, which most people do opt to do. I have a young adult who was born overseas and can't access any documented vaccination history, but says she has had all her vaccination, childhood vaccinations. What would I give her? Well, you have to assume she's not vaccinated. Her word, a verbal history of vaccination is not a sufficient evidence of vaccination. So your options are to do some serological testing. So you could check her Hep B immunity, her measles, mumps, rubella, and her varicella immunity. But for everything else, you would have to assume she's unvaccinated and then formulate a catch-up plan using the catch-up calculator. So as far as revaccination, parents, so the question is, parents, a father, does he need a repeat vaccine for every child? So that goes back to the 10-yearly recommendation. The recommendations state that if somebody's been vaccinated in the last 10 years and they're a close contact of a newborn, then that's sufficient. But like I said, we know immunity wanes from 2 years and rapidly from 5. So if the dad was vaccinated a year ago, you wouldn't be advising revaccination. But if they're getting towards that 5-year point, then maybe they want to think about getting that vaccine. All right, I'll find out about the new schedule and where you can get it from, and I'll email.
PHN can provide
Oh,
the
okay.
schedule, apparently.
Oh, okay,
So
there you
if
go.
they would like to contact us.
There you go. So the Primary Health Network have copies of the schedule, so you can contact them and they'll send them out to you. So since meningococcal W is noted to be more severe than other strains, we recommend starting Nimenrix earlier than 12 months and complete the full schedule like Bexsero. So the recommendations are that meningococcal ACWY can be given from 6 weeks of age. It's not funded. So it's around the funding of the vaccine. Like I said, we see bigger incidence in under 2s and then a spike again in adolescents. So we give it from 12 months on our schedule. That's when it's funded, but it can be given privately from 6 weeks of age, and it is recommended. And I think that's everything. Let me see. Yes, I think I've covered everything. Thank you, everybody, for your patience and for hanging around if you did. I went well over time. My first time on a webinar, so that's my excuse.
You did a great job.
Thank you.
Thanks. And again, thank you to the wonderful Sally. We really appreciate the informative presentation. And we'll see you next time. Good evening, everyone. Bye-bye.